So we'll be talking now about the cardiovascular system. So the cardiac looping, the first functional organ in vertebrate embryo, beats spontaneously by fourth week of development. Primary heart tube loops to establish the left-right polarity begins in fourth week of development, and there is defect in the left-right dynein involved in the left-right asymmetry leading to dextrocardia as seen in Carter syndrome. So we'll be talking about the atria. Here the septum primum grows towards the endocardial cushion, narrowing the ostium primum, and ostium secundum forms in the septum primum due to cell death. After this, the uh, septum secundum develops on the right side of the septum primum, and septum secundum expands and covers most of the ostium secundum. The remaining portion of septum primum forms the one-way wall of the foramen ovale. Most important, septum primum closes against the septum secundum, sealing the foramen ovale soon after birth. Septum secundum and septum primum fuses during infancy, forming the atrial septum. But the conditions can be patent foramen ovale, which is the failure of fusion of septum primum and septum secundum, and there can be paradoxical emboli, venous thromboembolism entering the systemic arterial circulation through right to left shunt in the ASD. So in case of ventricles, we have the muscular interventricular septum forms opening of interventricular foramen. Aortic pulmonary septum rotates and fuses with the muscular septum to form the membranous interventricular septum closing the interventricular foramen. Most important and very high yield, growth of endocardial cushion separates the atria from ventricle and contributes to both arterial septation and membranous portion of interventricular septation. Whereas the outflow tract, the neural crest cells migrates and truncal and bulbar ridges that spirals and fuse to form the aortic pulmonary septum, ascending aorta and pulmonary trunk. So anomalies can be transposition of great vessels, tetralogy of Fallot, and persistent truncus arteriosus. The valve, all four are valves are formed by the endocardial cushions of their respective places. Whereas the fourth arch, we can see on the in the third arch, that is CAP mnemonic, we have arch. So the aortic derivatives develops into the atrial septum, and the third arch we remember the common carotid artery and proximal part of internal carotid artery. On the fourth, we can remember on the right, it was the right proximal part of right subclavian, and on the left it was aortic arch. When we see, remember the sixth, it was the proximal part of pulmonary artery, and on the left it was ductus arteriosus. So the heart embryology, the truncus arteriosus is trunk, so it is formed on the pulmonary aorta. We have the bulbous cordis, that is the bulb. So bulb is present in the smooth part outflow tract of the left and the right ventricle. That's the bulbous cordis. So the primitive ventricular atrium is means trabeculated part. Okay, so trabeculated part is formed by the respective primitive ventricle or primitive atrium. Whereas when talking about the smooth part, so smooth part of the right atrium is formed by right horn of sinus. Just remember the photo that I have drawn, and the left atrium smooth part is formed by pulmonary vein. Similarly, the superior vena cava and the inferior vena cava. Superior vena cava is formed by right common cardinal vein and right anterior cardinal vein, whereas the inferior vena cava is formed by posterior sub and supracardinal vein. So endocardial cushion forms the atrial septum, intermembranous membranous interventricular septum, and AV and semilunar valve. So the left horn of sinus venosus, that is the right worm is forming the right smooth right horn of sinus venosus is forming the smooth part of right atrium. So left horn of sinus venosus form the coronary sinus. Left for coronary sinus. Left horn of sinus venosus forms the coronary sinus. Thank you. So when you talk about the fetal circulation, the umbilical vein has 80% saturated with the O2 with the pressure of PO2 is 30 mmHg, and umbilical artery has the low O2 saturation. Three important shunts. So blood entering the fetus through the umbilical vein is conducted by the ductus venosus into IVC, bypassing hepatic circulation. Most of the oxygenated blood reaching the heart by the IVC is directed through the foramen ovale into the left atrium, whereas the deoxygenated blood from the SVC passes from the right atrium to the right ventricle to the ductus arteriosus and descending aorta. So at birth, there is decrease in resistance in pulmonary vasculature and increase in left atrial pressure. Foramen ovale closes called fossa ovalis after closure. Increase O2 from respiration and decrease prostaglandin from placental separation, closure of the ductus arteriosus. Indomethacin helps closing the patent ductus arteriosus. And this remnant called ligamentum arteriosum. Prostaglandin E1 and E2 keeps the PDA open. Whereas when we talk about the ductus word, there is something issue with the ligamentum and the ductus arteriosus near the left recognitional nerve. Foramen oval forms the fossa ovalis, whereas the allantois forms the median. Allantois says AN, so it forms the median, MEDIAN, median umbilical ligament, whereas the umbilical is AL, so it forms the medial, MIDIAL ligament. Umbilical vein ligamentum teres hepatis, round ligament, and is confined in falciparum ligament. So, talking about the autogener syndrome, which is the compression of the mitral stenosis, there is leading to compression of the esophagus called dysphagia, and recurrent laryngeal nerve problem, branch of vagus nerve cause hoarseness, that is called autogener syndrome. So the LAD supplies the anterior two-third of interventricular septum, anterolateral papillary muscles, and anterior surface of the left ventricle, whereas PDA supplies the posterior one-third, that is posterior descending artery, supplies the posterior one-third of interventricular septum, posterior two-third of the ventricles, and posterior medial papillary muscles. So the right acute marginal artery supplies the right ventricle. In dominance, right dominance PDA posterior arises from the right coronary artery, which is most common, but if it arises from the LCX, it is called left dominance. And thank you. So the talking about the cardiac physiology. So stroke volume affect contractibility, afterload and preload. So increase in preload during the early pregnancy. So the CB cap is the mnemonic, that is stroke volume affects the cap, that is C for contractibility, afterload and preload affected by. So contractibility, when we talk about the contractility, the catecholamines stimulates the beta 1 receptors, activates the protein kinase, activates the phospholamine phosphorylation, and increase calcium inside the cells. Whereas next what it does, decrease in extracellular sodium, decrease activity of sodium calcium exchanger. So digoxin acts here like blocks the sodium potassium pump, whereas it indirectly blocks the sodium calcium pump. So sodium potassium, sodium calcium, so increasing the intracellular calcium. Decrease contractibility or decrease the stroke volume. And from the beta 1 blockade we can decrease the CMP, heart failure with the systolic dysfunction. Acidosis also decreases the heart contractibility. Contractibility or stroke volume is decreased by decrease in PaO2 and increase in PCO2, and it is also decreased contractibility by non-dihydropyridine calcium channel blockers. So when you talk about the preload, is approximated by ventricular and diastolic volume, and it depends upon the venous tone and circulating blood volume. So preload depends upon the venous tone and circulatory blood volume. So venodilators like nitroglycerin decreases the preload. When you talk about the afterload, is approximated by mean arterial pressure. So arteriodilators decreases the like the hydrolyzin decreases the afterload. So in order to decrease the preload, nitroglycerin; in order to decrease the afterload, we have the hydrolyzin. AC inhibitors, ARB inhibitors decreases both preload and afterload. Chronic hypertension, there is increase in mean arterial pressure, and there is left ventricular hypertrophy. So for myocardial oxygen demand, we have the CAR myocardial, so CARD. So C for increase in contractibility, increase afterload, increase heart rate, and increase diameter of ventricles, increases myocardial oxygen demand. Wall stress is directly proportional to pressure times radius divided by 2 times of wall thickness. So the ejection fraction is is a stroke volume, that is stroke volume is equal to end diastolic volume minus end systolic volume, which is divided by end diastolic volume. So ejection fraction is the index for ventricular contractility, decrease in stroke volume, systemic heart failure, and usually normal in diastolic heart failure. Cardiac output is equals to stroke volume times heart rate. Cardiac output is also equals to rate of oxygen consumption divided by difference in O2 content of atrial minus venous. So in later stage, cardiac output is maintained only by increase in heart rate only, that is SB gets plateau. So in diastolic is when there is increase in heart rate, there is decreased diastolic filling, decreased stroke volume, and decrease in cardiac output. So pulse pressure is difference between systolic and minus diastolic, and is proportional to stroke volume and inversion to arterial compliance. Increased pulse pressure in hyperthyroidism, aortic regurgitation, aortic stiffening, obstructive sleep apnea, anemia, exercise, and decreased pulse pressure in aortic stenosis, cardiogenic shock, cardiac tamponade, and advanced heart failure. Mean arterial pressure is equals to cardiac output times total peripheral resistance. MEP is equals to 2/3 of diastolic blood pressure plus 1/3 of systolic blood pressure, is equivalent to diastolic blood pressure plus 1/3 of pulse pressure. Force of contraction is proportional to end of diastolic muscle of cardiac muscle fibers preload. So now we'll be talking about the volumetric flow rate is equals to flow velocity times cross section area. So Q is equals to volumetric flow rate is directly proportional to radius times R4, and resistance inversely proportional to 1 by R4. So resistance is equals to 8 times N, viscosity times length divided by pi r square. So vein has most of the blood storage and viscosity decreases with the anemia. In negative inotropes, we have the heart failure with reduced ejection fraction, narcotic overuse, or sympathetic inhibition. Similarly, venous return is decreased in case of acute hemorrhage and spinal anesthesia, and total peripheral resistance is decreased with the exercise and arteriovenous shunt. So arteriovenous shunt decreases the total peripheral resistance. So change often occurs in the tandem and may be reinforcing. Exercise increases chronotropic and decreases total peripheral resistance to maximize the cardiac output, or compensatory heart failure decreases the in heart failure decrease the inotrope fluid retention to increase preload to maintain the cardiac output. So pressure, volume, loop, and cardiac cycles is we have the first the feeling. The mitral valve opens at the leftmost, and then there is the S3 heart sound, which is the early feeling, and there is S4 heart sound, which is the late feeling. So S3 heart sound is increased feeling pressure. So with the S3 heart sound is heard nearly in MR, AR, and heart failure, thyrotoxicosis, and is more common in dilated ventricles. So volume causes this. So normal in children, young adults, athletes, and pregnancy. Turbulence causes caused by the blood flow from LA mixing with increased end stroke volume. Whereas S4 is in the late diastole, which is seen in the stiffened left ventricle in the hypertrophy like hypertension. So after that, the mitral valve closes on the rightmost part, and then there is the isovolumetric contraction period between the mitral valve closing and aortic valve opening, period of highest O2 consumption, that is during the systolic ejection. After that, there is a systolic ejection, then there is isovolumetric relaxation. So period between the aortic valve closing and mitral valve opening. So rapid filling and reduced filling I have already talked about. So in the jugular venous pressure, we have the things called A is atrial contraction absent in atrial fibrillation, whereas the COPC is right ventricle contraction, closed tricuspid valve bulging into atrium, axis descent, so atrial relaxation and downward displacement of closed tricuspid valve during rapid ventricular ejection phase, reduced or absent in tricuspid regurgitation, right heart failure because of pressure gradients are reduced. V wave is equals to increased RA pressure due to increased volume against closed tricuspid valve. V wave is increase in RA pressure due to increased volume against closed tricuspid valve. Y descent is RA emptying into RV, prominent in constrictive pericarditis and absent in cardiac tamponade. Y descent is RA emptying, empty, Y for empty, RA empty into the right ventricle. So V wave is volume against closed tricuspid valve. So increased RA pressure, V wave is equals to increased RA pressure due to increased volume against closed tricuspid valve. And X descent means atrial relaxation and downward displacement of closed tricuspid valve during rapid ventricular ejection. So we have the aortic stenosis, which is like rocket. Both the graphs, left ventricular pressure and left volume graph with respect to BP and time. So in aortic stenosis, left ventricular pressure is greater than aortic pressure. So there is increase in left ventricular pressure, increase in end systolic volume, no change in end diastolic volume. In aortic stenosis, there is decrease in stroke volume, there is ventricular hypertrophy, decreased ventricular compliance, and increase in end diastolic pressure for given end diastolic volume. In aortic regurgitation, which is like the pressure volume and the left ventricle volume and pressure, it is like Bakundo. So initially the football is inside the initial curve, and the BP and the time graph for the aortic regurgitation is coincides, so it's together in the same curve. So large pulse pressure can be seen. So here in aortic regurgitation we have no true isovolumetric phase. So increase in end diastolic volume, increase in stroke volume, and loss of dicrotic nodes. Loss of dicrotic nodes is very important in the case of aortic regurgitation. So next is mitral stenosis. So mitral stenosis, what happens? The initial black line, the little bit, the yellow green line goes beyond the left side of the line. So that is in the LV and left volume curve. And whereas when we look over the pressure wall in mitral stenosis, we look the pressure, blood pressure and time. So the here is LA pressure is greater than left ventricular, right atrial pressure is greater, left atrial pressure is greater than left ventricular pressure. Increase in LA pressure, decrease in end diastolic volume, decrease in end systolic volume, and decrease in stroke volume. Whereas in mitral regurgitation, again a football has come, but the football now in mitral regurgitation goes beyond left side, whereas in aortic regurgitation it remains inside, the football remains inside, whereas mitral regurgitation the football goes higher side. And the BP and the time curve, they are presence of tall V wave, and no in mitral regurgitation there is no true isovolumetric phase. Decrease in end stroke volume due to decreased resistance, increased regurgitation into LA during systole, increased end diastolic volume due to increased LA volume pressure from regurgitation, increased ventricular filling, increase in stroke volume, forward flow into systemic circulation plus backward flow in LA. So in the A's, there is increase in systolic BP, decreased diastolic BP, and increase in pulse pressure. Pulse pressure is increase in age, exercise, and thyroid condition, whereas the diastolic BP decreases in according to age, and thyroid decreases. Whereas in exercise, the diastolic BP remains unchanged, or there is slight increase in diastolic BP. So similarly, we have the physiological splitting, which is normal. That is the since during the inspiration, right side of heart gets more blood, so there is delayed closure of the pulmonary valve. So decreased pulmonary impedance, increased capacity of pulmonary circulation occurs during inspiration. So wide split is the condition like the pulmonary stenosis or right bundle branch block. There is delayed pulmonary sound, especially on inspiration. So why there is a wide split that is seen in pulmonary stenosis, and wide split of P2, that is the pulmonary stenosis right bundle branch block. So we have a fixed split that is seen in the ASD. So here the left to right shunt, increase RA and RV volume, increase flow through pulmonary valve, delayed pulmonary valve closure, which is independent of respiration. So paradoxical split is like when you have the aortic stenosis or left bundle branch block. So here the A2 paradoxically splitting P2 occurs before A2. So A2 here closes on lead. So paradoxical means A2 closes late. Wide split means P2 closes more delayed. Okay. So now we have the aortic, the mitral area. We have the MS, the sound heard in the mitral area are holosystolic murmur, the mitral regurgitation, the systolic murmur of mitral valve prolapse, and the diastolic murmur of mitral stenosis. Okay, and the tricuspid area, similarly we have holosystolic murmur of the tricuspid regurgitation and ventricular septal defect, and the diastolic murmur of tricuspid stenosis. So stenosis and regurgitation taken on by the mitral and tricuspid area, whereas the aortic area has the only the stenosis part, and the pulmonary area have also the only stenosis part, but the pulmonary area loves the ASD, so ASD is there. So we have the left sternal border. Okay, so in the left sternal border we have the PDA. Okay, so and aortic regurgitation and hypertrophic cardiomyopathy is also in this area. Okay, so okay, and so serially we have ASD, PDA, and VSD on the left side of the heart. So on standing and valve support, okay, so the murmur that gets increases is MBP and HCM. Okay, and most of the murmur gets increased during the squatting, large passive leg raise. Okay, but during the passive leg raise and squatting, there is the decrease in MBP and HCM. Okay, and hand grip there is increase in afterload. Squatting increases preload and afterload both. Passive leg raise increases the preload. Standing decreases the preload. In inspiration, the most right-sided murmurs are prominent, whereas during the expiration, the left-side murmurs are prominent. So hand grip, there is the increase in the AR, MR, and BSD, whereas decrease in AS and HCM is decreased. So we'll be talking now about the aortic stenosis, which has like crescendo, decrescendo, systolic ejection murmur, and soft S2 ejection click may be present. So in aortic stenosis between the S1 and S2, there is a sound, okay, and it is like left ventricular pressure is greater than aortic pressure during systole, loudest at the base and radiates to carotid. Pulses parvus et tardus. Pulses are weak with delayed peak and can lead to syncope, angina, dyspnea, and exertion. So SAD is the mnemonic with AS. Syncope, angina, and dyspnea most commonly due to the age-related calcification in older age greater than 60 or in young patient with early onset calcification of bicuspid aortic valve. So next is the mitral or tricuspid regurgitation. So both has the holosystolic high-pitched blowing murmur. Mitral loudest at the apex and radiates towards the axilla. So the MR and TR radiates to the axilla. MR is often due to ischemic heart disease like post-MI, MBP prolapse, or LV dilatation. Tricuspid loudest at tricuspid area. TR common caused by RV dilatation. Rheumatic fever, infiltrate carditis can cause either MR or TR. So next is mitral valve prolapse. Late systolic crescendo murmur with mid systolic click. Due to sudden tensioning of cauda tendineae as the mitral leaflet prolapse into LA, cauda cause crescendo with click. Best heard at over apex, loudest just before S2, usually benign, can predispose to infective endocarditis, can be caused by myxomatous degeneration, such as MBP is seen in Marfan, Ehlers-Danlos, rheumatic fever, and cauda rupture. We have now the ventricular septal defect, which is the holosystolic harsh sound murmur, loudest at tricuspid area. Large VSD have low intensity murmur than the small VSD. Now these were all the systolic murmur includes the aortic stenosis, mitral valve or tricuspid regurgitation, mitral valve prolapse, and ventricular septal defect. So stenosis of the aorta, and whereas the regurgitation of the mitral and tricuspid causes the systolic murmur. Now we'll be talking about the diastolic murmurs. So for the diastolic, we have aortic regurgitation, that is the sounds are heard after S2. So diastolic murmur sounds are heard after S2. So in cases of aortic regurgitation, we have high pitched blowing early diastolic crescendo murmur, best heard at the base, and aortic root dilatation or left sternal border. On long diastolic murmur, hyperdynamic pulse, there is head bobbing when severe and chronic. Wide pulse pressure. Cause includes bicuspid beer. Beer is the cause of aortic regurgitation. So B for bicuspid aortic valve, E for endocarditis, A for aortic root dilatation, and R for rheumatic fever. Progress to left heart failure. So in cases of mitral stenosis, there is is also after S2 is a diastolic murmur and OS. So opening snap is heard in the mitral stenosis due to abrupt halt in the leaflet motion in diastole after rapid opening due to fashion at the leaflet tip. Delayed rumbling and middle to late diastolic murmur. Decrease interval between S2 and OS correlates with increased severity. LA pressure greater than LB pressure during diastole. Often at late, sequelae of rheumatic fever, chronic MS can lead into pulmonary congestion, hypertension, and LA dilatation, atrial fibrillation, and Ortner syndrome. So patent ductus arteriosus. Continuous machine-like murmur, best heard at the left infraclavicular area, loudest at S2, often due to congenital rubella or prematurity. Patent ductus arteriosus is a continuous machine-like murmur, best heard at the left infraorbital area, loudest at S2, often due to congenital rubella or prematurity. Often need a patent for the machine. So when you talk about the myocardial action potential, we have the graph for the cardiac myocytes, in which there is a phase 0, there is rapid upstroke and depolarization, voltage gated sodium channel open. Phase 1 is the initial repolarization. Inactivation of voltage-gated sodium channel and voltage-gated potassium channel begins to open. Now we have the phase 2, which is calcium is the down here. Plateau, influx through the voltage calcium channel, balance potassium efflux. Calcium influx trigger calcium release from sarcoplasmic reticulum and myocyte contraction, excitation, contraction, coupling. Next is the phase 3, where is the rapid depolarization matches potassium efflux due to opening of voltage gated slow delayed rectifying potassium channel and closure of the voltage gated calcium channel. Then we have the phase 4, that is the resting potential, higher potassium permeated through the potassium channel. In contrast to skeletal muscle, cardiac muscles action potential has plateau due to calcium influx and potassium influx. So plateau is there. Cardiac myocyte contraction requires calcium influx from ECF to induce calcium release from sarcoplasmic reticulum. So calcium induced calcium release. Cardiomyocytes are electrically coupled each other by gap junction. When we talk about the SA node and AV node, the key difference from ventricular action potential is it has only phase 0, 3 and 4. So 4, 0, 3 is the only phase. So in phase 4, which is the slow spontaneous diastolic depolarization due to funny current, IF channel responsible for slow mixed sodium in potassium inward current, different from INA in phase 0 of ventricular action potential. Account for atomicity of SA and AV node. The slope of phase 4 in SA node determines the heart rate. ACH adenosine decreases the rate of diastolic depolarization and decreases the heart rate, while catecholamines increases depolarization and increases heart rate. Sympathetic stimulation increases the chance that IF channel are open and thus increase heart rate. Now we have the phase 0, the upstroke opening of the voltage gated calcium channel. Fast voltage gated sodium channels are permanently inactivated because the less negativity resting potential of these cells result in slow conduction velocity that is used in the AV node to prolong transmission from atria to ventricle. So phase 1 and 2 are absent. In phase 3, there is a repolarization, inactivation of calcium channels, and increased activation of potassium channels, increased potassium efflux. So there is increase in capillary pressure in heart failure, increased capillary permeability in toxins, infections and burn. There is increase in interstitial fluid oncotic pressure in lymphatic blockage, and decrease in plasma protein in nephrotic syndrome, liver failure and protein malnutrition. So there is something called auto-regulation. So skeletal muscles has the auto-regulation with the mnemonic chalk. So C for carbon dioxide. There is think of the during exercise. So C for carbon dioxide, H for H plus, A for adenosine, L for lactate, and K for potassium. At rest, sympathetic tone in the arteries. So in the brain, the local metabolite vasodilatory autoregulation is from carbon dioxide and pH. And so similarly in the heart we have the NO, carbon dioxide, and decrease O2. So local metabolite that is vasodilatory are NO, CO2 and decrease NO. Whereas in the brain, local metabolite that are vasodilatory is CO2 and pH. Whereas in kidney it is myogenic and tuberoglomerular feedback. Whereas in the lungs is hypoxia causes vasoconstrictions. In the skin we have the sympathetic vasoconstriction, most important mechanism for temperature regulation. The pulmonary vasculature is unique in that alveolar hypoxia causes vasoconstriction so that the well ventilated area are perfused. In other again, hypoxia causes vasodilation. So we need to know about the different cardiac pressures. So in the normally the pressure in the superior vena cava right atrium is less than 5, whereas the in the pressure in the right ventricle is 25/5, and in the pulmonary artery we have 25/10. Similarly, the pressure in the left atrium is less than 12, whereas the pressure in the left ventricle and the aorta, left ventricle pressure is 130/10, and whereas in the aorta it is 130/90. Pulmonary capillary waist pressure is 4 to 12. So pulmonary capillary waist pressure is good approximate of left atrial pressure. In mitral stenosis, pulmonary capillary waist pressure is greater than left ventricle and diastolic pressure. PCVT is measured with pulmonary artery catheter, Swan gauge catheter. So similarly, so ANP causes decrease in sodium reabsorption at the renal collecting tubules, dilates afferent renal. ANP dilates the afferent renal arterioles and constricts the efferent arterioles, promoting diuresis and contributing to aldosterone escape mechanism. Whereas the B-type natropeptide released from the ventricle myocytes are increased response of tension. Similar physiology action to ANP with longer half-life. BNP blood test used to diagnosing for heart failure, and very good negative predictive value available in recombinant from nesiritide for treatment of heart failure. Available as a recombinant form, nesiritide for treatment of heart failure. So when you talk about the electrocardiogram, the speed of conduction in his bundle of his Purkinje's fiber is 22 millisecond, whereas in the atria it is 1.1 millisecond. Then in the ventricles is 0.3 second. Then in the AV node it is just 0.05 second. So he parts at left ventura, AV venue. So first, when you talk about the speed of conduction, first is his bundle Purkinje, then we have the atria, ventricle, then the AV node. Whereas when you talk about the rate, it is the SA node greater than AV node. Purkinje rates are SA node greater than AV node, greater than bundle of his is greater than Purkinje ventricles. So AV node located at the posterior inferior part of intra-arterial septum. So blood supply from RCA, 100 millisecond delay, allow time for ventricular filling. SA node located at RAN, superior vena cava, pacemaker inherent dominant with slow phase of obstruct. So the conduction pathway from SA node to atria, then to AV node, then to bundle of his, then his and left bundle branches, Purkinje fibers, then ventricles and left bundle branch into left anterior and posterior fascicles. So we have the PR interval, the time from start of atrial depression to start of ventricular depression, normally 120 to 200 milliseconds. QRS complex normally less than 100 milliseconds. And QT interval is the ventricular repolarization, and the T wave is the ventricular repolarization. T wave inversion may indicate ischemia or recent MI. J point junction between the end of QRX complex and start of ST segment, whereas the ST segment is isoelectric ventricle depolarized. U wave is prominent in hypokalemia. Think U wave, hyperukalemia and bradycardia. So similarly, we have baro and chemoreceptor. So the basically when you talk about the receptor, aortic arch transmitted by the vagus nerve. Okay, aortic arch transmitted by vagus nerve to solitary nucleus of medulla, response to change in BP. Also we have the carotid sinus, delayed region superior to bifurcation of carotid artery, transmitted by glossopharyngeal nerve to solitary nucleus of medulla, response to change in BP. So we have now the chemoreceptor, that is peripheral. Carotid and aortic bodies are stimulated by increase in PCO2, decrease pH of blood, and decrease in PaCO2 less than 60 ml/Hg. Central are stimulated by change in pH and PCO2 of the brain. Interstitial fluids, which is in turn are influenced by atrial CO2, as plus cannot cross the blood-brain barrier. Do not directly respond to PO2. Central chemoreceptors becomes less responsive with chronically increase in PaCO2 like in COPD. So increased dependence on peripheral chemoreceptor to detect the decrease in O2 to drive the respiration. So baroreceptor are there. These were the chemoreceptor. Baroreceptor, when there is hypotension, there is decrease in atrial pressure, decrease stretch, decrease afferent baroreceptor firing, and increase in efferent sympathetic firing, and decrease in efferent parasympathetic stimulation. So vasoconstriction, increase heart rate, increase contractility, increase BP. Important in response to severe hemorrhage. Now we have carotid massage, increase pressure, carotid sinus, increase stretch, increase afferent baroreceptor firing, increase AV node refractory period, and decrease in heart rate. So component of Cushing reflex is triad of hypertension, bradycardia, and respiratory depression, whereas increase in intracranial pressure constricts arterioles, cerebral ischemia, increase in PCO2, and decrease pH. Central reflux, sympathetic, increase in perfusion pressure, hypertension, increase stretch, peripheral reflex, baroreceptor, induced bradycardia. Thank you for physiology cardiovascular. So welcome to the cardiopathology. So we'll be talking about the cardiac myxoma starting from here. So most cardiac tumors is a metastasis. Example, melanoma is the most common. Most common primary cardiac tumor in adult is in the atrium, mostly left atrium, that is myxoma, and usually they are ball valve obstruction in the left atrium, and is with the multiple syncope episode. Interleukin 6 is produced by the tumor. Constitutional symptoms like fever, weight loss, and may auscultate early diastolic tumor loop sound. Histology, gelatinous material, myxoma cells emerged in glycosaminoglycans. And we have the rhabdomyolysis, which occurs in the children and is associated with the tuberous sclerosis. Histology shows hematomous growth, more common in the ventricles. We have Kussmaul signs, that is paradoxical increase in JVP on inspiration. So normally inspiration decreases the JVP. So impaired in right ventricular feeling, and mostly seen in constructive pericarditis, restrictive cardiomyopathy, right heart failure, passive pulmonary embolism, right atrial or venous tumor. So here there is the impaired right ventricular feeling, decreased venous return as the negative thoracic pressure is sufficient to bring the blood to right heart and is the Kussmaul sign. Next we have the hereditary hemorrhagic telangiectasia, also known as the Osler-Weber-Rendu syndrome, is the autosomal dominant of blood vessels, and there is telangiectasia on the skin and mucous membrane, recurrent epistaxis and skin discoloration, arteriovenous malformation, GI bleeding, hematuria. So skin and mucous membrane, recurrent epistaxis, skin discoloration, arteriovenous malformation, GI bleeding and hematuria. So the next topic is the acute pericarditis, which is simply relieved by sitting up and leaning forward, and is often complicated by pericardial effusion, and there is presence of frictional drop. ECG shows the widespread ST elevation and or PR depression. Causes of acute pericarditis is most commonly the presumed viral, or it could be Coxsackie virus, neoplasm, autoimmune, SLE, rheumatic arthritis, uremia, cardiovascular, acute ischemia, or Dressler syndrome. Radiotherapy also. So treatment of acute pericarditis is NSDs, colchicine, glucocorticoid, or dialysis. In cases of myocarditis, which is global enlargement of the heart and dilation of all the chambers. Measure of cause of SCD in child less than 40 years. Present with highly variable and includes dyspnea, chest pain, fever, arrhythmia. Persistent tachycardia out of proportion of fever is characteristic. Very high yield for myocarditis is persistent tachycardia out of proportion to fever is characteristic. So we have the multiple causes of myocarditis includes the viral, adenovirus, Coxsackie virus, parvo V19, HIV, HSV6, lymphocytic infiltrate with the focal necrosis, and parasitic Trypanosoma cruzi, Toxoplasmosis gondii, Borrelia burgdorferi, Mycoplasma pneumoniae, Corynebacterium diphtheria, carbon monoxide, black widow venom, rheumatic arthritis, doxorubicin, cocaine, autoimmune diseases like Kawasaki disease, sarcoidosis, SLE, and polymyositis dermatitis. So, basically, multiple causes of myocarditis includes the viruses. The parasites, the bacterial, the toxins, rheumatic arthritis, drugs like doxorubicin and cocaine, and autoimmune there is Coxsackie disease, sarcoidosis, SLE, polymyositis, dermatomyositis. The complications include sudden death, arrhythmia, heart block, dilated cardiomyopathy, heart failure, viral thrombus with systemic emboli. So now we have the rheumatic fever. Cases of rheumatic fever, here the affected valve mitral is greater than aortic is greater than tricuspid. Okay, and there is something called the we know the Jones criteria, and there is early lesion in mitral valve regurgitation, late lesion is mitral stenosis, as with the ascop bodies, granuloma with the giant cells, and there is antiscop cells, enlarged macrophage with ovoid wavy rod-like nucleus, and there is the immune-mediated type 2 hypersensitivity, and protein cross-react with the self-antigen, and there is molecular mimicry, and there is syndrome and chorea, which is involuntary irregular movement of limb and face, and there is erythema marginatum, that is effervescent rheasis with the ring margin. We have the syphilis. Third, syphilis disrupts the vasa vasorum of the aorta with consequent atrophy of the vessel wall and dilatation of the aorta and the valve ring. May see calcification of the aortic root, ascending aortic arch, thoracic aorta leads to tree bark appearance of aorta. Can result in aneurysm of ascending aorta or aortic root or aortic insufficiency. So we have the bacterial endocarditis, which is having required multiple blood culture for diagnosis. If culture negative, most likely Coxiella brunneti or Bartonella species. So the most mitral valve is the most affected in endocarditis, bacterial endocarditis. Tricuspid valve endocarditis associated with the IV drug use, associated with the S. aureus, Pseudomonas candida. And there is S. bovis, which is present in colon cancer, S. epidermidis on prostatic valve. Okay, and there is native valve endocarditis, Heck organism, that is Haemophilus agitobacter, formerly Actinobacillus, Cardiobacterium Iganella, Kinganella. So next is the acute, the S. aureus is the highly virulence and vegetation on the previous normal valve. Subacute we have the viridans, small vegetation on congenitally abnormal disease called sequelae of dental procedures. So viridance symptoms: fever, new murmur, rough spots. This is a round white spot on the retina surrounded by the hemorrhage. Osler's nodules, that is ouchy, raised lesion on the finger or toe pad due to immune complex deposition. We have Genevieve lesion, small painless erythema lesion on palms and soles. Splinter hemorrhage on nail bed. As with the glomerulonephritis, septic arthritis, or pulmonary emboli, may be non-bacterial or secondary to malignancy, hypercoagulation, or lupus. So we have the distributic shock, which is sepsis and analysis, which is the worm. So there is decrease in SBR, increase in cardiac output, and decrease in PCWP. Whereas the in CNS injury, there is the similar as the distributive shock, except the in the CNS injury there is decrease in SVR, but the cardiac output here is decrease. In CNS injury there is decrease in cardiac output as well as decrease in SVR. Okay, and sepsis analysis causes worm, whereas CNS injury are dry. So now we'll be talking about the when there is like tension pneumothorax, or the pulmonary emboli, the PCWP decreases, whereas the cardiac tamponade, PCWP increases. Very high yield. Okay, so in cases of cardiac tamponade, there is the compression of the heart by fluid in all the chambers. So there is a back with the cardiac tamponade. So there is hypotension. Back stride is hypotension, distended neck bends, and distant heart sound. Increased heart rate, pulse pressure, ECG shows low voltage QRX and electric alterance. Okay, due to swinging movement. And treatment is pericardiosynthesis or surgical drainage. Pulsus paradoxus, decrease in amplitude of systolic BP greater than 10 mmHg during inspiration. We are seen in quote. So pulsus paradoxus is in quote, that is constrictive pericarditis, obstructive pulmonary disease, group OSA, asthma and COPD, and cardiac tamponade. So the next is we are having the what happens in the heart failure. So right heart failure, there is hepatomegaly, that is SUV did not make liver. Okay, and there is increase in CVP, increase in resistance to portal flow, cardiac cirrhosis would be there. There is increase in JVP, and there would be pulmonary edema due to increased venous pressure and fluid retraction. Okay, so basically there is activation in heart failure. There is including a RAS system and increase in sympathetic tone. So increased sympathetic tone acts on the beta 1 and the alpha 1. So catecholamines beta 1, there is increase in contractility and increase in heart rate, whereas the alpha 1 catecholamines and the angiotensin 2 causes vasoconstrictions. Okay, and angiotensin 2 aldosterone ADS2 increases circulatory volume. So in left heart failure we have the orthopnea, paroxysmal nocturnal dyspnea, and the pulmonary edema. So orthopnea is the shortness of breath when supine, increased venous return from the distribution of blood. Paroxysmal is breathless occurring from sleep, increased venous return from distribution of the blood. And there is pulmonary edema, that is increased pulmonary venous pressure, pulmonary venous distension, and transduction of fluid. Absence of hemostatic lateral heart failure cells in lungs. So in the heart failure we have the systolic dysfunction. In the systolic and diastolic dysfunction, what happens? In the systolic dysfunction there is reduced in ejection fraction, and there is the increase in end diastolic volume, decreased contractility due to the secondary ischemia, MI, or dilated cardiomyopathy. Whereas in diastolic dysfunction there is preserved ejection fraction and normal end diastolic volume. So in diastolic failure there is the normal end diastolic volume, whereas the end diastolic volume is increased in systolic. Very high yield. Okay, very high yield, and there is decreased compliance and increase in end diastolic pressure. So and diastolic dysfunction means there is increase in diastolic pressure but the volume remains normal. Very high yield. Once the diastolic dysfunction, there is increase in pressure but the volume remains normal. Volume is normal in diastolic dysfunction, there is increase in diastolic pressure, the volume is normal, whereas the increased volume in the what you call so that there is a difference between only the end diastolic volume is increased in systolic volume, whereas the diastolic there is normal EDB. Whereas decreased compliance often secondary to myocardial hypertrophy. So myocardial hypertrophy causes diastolic dysfunction, whereas the dilated cardiomyopathy causes this systolic dysfunction secondary to IM ischemia or MI. So right heart failure results from the left heart, or results isolated right heart failure due to pulmonary cause. So angiotensin inhibitor or angiotensin 2 receptor blockers, beta blockers, spiralactones decrease mortality, loop dietary and thiazide are primarily used for symptomatic relief. Hydrolyzing with nitrite therapy improves both symptoms and mortality in selected patients. So we have the dilated cardiomyopathy and the hypertrophic cardiomyopathy and the restrictive infiltrative cardiomyopathy. So the dilated cardiomyopathy is often mostly cardiopathy, 90% of the case, is often associated idiopathic or familial due to mutant TTN gene encoding the sarcolemma protein titin. So often the TTN gene is associated with dilated cardiomyopathy, sarcolemma protein titin. Causes of dilated cardiomyopathy includes alcohol, cocaine, doxorubicin, infection, Coxsackie virus, Chagas disease, ischemia, systemic conditions like hemochromatosis, sarcoidosis, thyrotoxicosis, and wet beriberi, and peripartum cardiomyopathy. So it leads to systolic dysfunction. Okay, and there is dilated cardiomyopathy displays eccentric hypertrophy, that is sarcomere is added in series. Eccentric means sarcomere. There is Tokugawa cardiomyopathy, broken heart syndrome, also called the ventricular apical ballooning, like due to increased sympathetic stimulation is stressful stimulation. So there is the ventricular apical ballooning in Takasaki cardiomyopathy is like stressful situation. So the finding in dilated cardiomyopathy is heart failure, S3 heart sound, systolic regurgitation murmur, dilated heart and echocardiogram, balloon appearance of heart on chest X-ray. So the treatment is sodium restriction, AC inhibitors, beta blockers, sacubitril, diuretics, mineralocorticoid receptor blockers, spirulactons, digoxin, ICD, and heart transplant. We have the hypertrophic cardiomyopathy. There is the 60 to 70% case is autosomal dominant, OMIMG. It is autosomal dominant, most often due to the mutation in the gene encoding the sarcomere protein due to the myosin binding protein and myosin heavy chain. So there is gene encoding sarcomere protein such as myosin binding protein C and beta myosin heavy chain. Cause syncope during the exercise may lead to sudden death young athletes due to ventricular arrhythmia. So finding in hypertrophic cardiomyopathy as per heart sound, systolic murmur may see mitral regurgitation due to impaired mitral valve closure. So diastolic dysfunction ensures hypertrophic cardiomyopathy has the concentric hypertrophy, sarcomere added in the parallel, and often septal predominance, myofibrillar dysarray, and fibrosis. So hypertrophic cardiomyopathy has myofibrillar dysarray and fibrosis, classified as the hypertrophic obstructive cardiomyopathy when the outflow from left ventricle is obstructed, asymmetrical left hypertrophy, and systolic anterior motion of the mitral valve, outflow obstruction, dyspnea, possible syncope. So other cause of concentric hypertrophy is chronic hypertension and Friedreich's ataxia. So next is restrictive infiltrative cardiomyopathy. So please help. Formula for the restrictive or infiltrative cardiomyopathy is post-radiational fibrosis, Loeffler syndrome. P for post-radiational fibrosis, L for Loeffler syndrome, E for endocardial fibroelastosis, that is thick fibroelastic tissue in the endocardium of your children. A is the amyloidosis, S for sarcoidosis and hemochromatosis. So amyloidosis, sarcoidosis, hemochromatosis causes restrictive cardiomyopathy. So it is also the diastolic disorders and have low voltage ECG despite heavy, thick myocardium, especially in myocarditis. We have the Loeffler's endocarditis associated with the hypereosinophilic syndrome. As histology shows eosinophilic infiltrate in the myocardium. In Loeffler endocarditis, we have the issue with the hypereosinophilic syndrome. Histology shows eosinophilic infiltrate in the myocardium. So similarly, we have the myocardial infection complication. There is cardiac arrhythmia occurs within the first few hours after MI. So the post-infarction fibrous pericarditis 1 to 3 days. So pericarditis is 1 to 3 days, that is the frictional rub. Papillary muscle rupture, that is the 2 to 7 day post medially papillary muscle rupture, increased risk of single blood supply from posterior descending artery and can result in severe mitral regurgitation. So next we have the interventricular septal rupture, that is in the 3 to 5 days, macrophage mediated degradation. VSD, increased O2 saturation and pressure in right ventricle. Next is ventricular pseudoaneurysm formation, that is 3 to 4 days, free wall rupture, contain all adherent pericardium or scar tissue, decrease cardiac output, increase risk of arrhythmias. Ventricular free wall rupture in 5 to 14 days, so that causes cardiac tamponade, LV hypertrophy. Previous MI protects against free wall rupture. Acute usually leads to sudden death. True ventricular aneurysm, 2 weeks to several months, outward bulge-like contraction, dyskinesia associated with the fibrosis. Dressler syndrome, severe weak autoimmune phenomenon resulting in fibrous pericarditis. So in left ventricle failure and pulmonary edema can occur secondary to left ventricular infarction, VSD. free wall rupture, papillary muscle rupture with mitral regurgitation. So acute coronary syndrome treatment is unstable angina, anticoagulation like heparin, anticoagulant therapy, aspirin, ADP receptor inhibition, clopidogrel, beta blockers, AC inhibitors, statins. Symptoms controlled with the nitroglycerin and morphine. And STEMI, in addition to above repurgent therapy, most important for percutaneous coronary intervention preferred over fibrinolysis. If RV affected, example RC occlusion, support venous return preload to maintain the cardiac output, IV fluid, and nitroglycerin. So in the ECG, if RR is far from P, then we have a first degree. Longer drop, then we have Wackenbach. If some P don't get through, then we have to Movis type 2. If P and Q don't agree, they have a third heart degree. So let's start with the first degree heart block, that if PR interval is prolonged greater than 200 milliseconds and benign and asymptomatic, no treatment required. We have the Movis type 1, that is progressive lengthening of PR interval until a beat is dropped, a P wave not followed by QRS complex, usually asymptomatic, variable RR interval with a pattern regularly irregular. Then we have the Movis type 2, drop beat that are not preceded by change in the length of the PR interval. So the type 1 and the Movis type 2 is having the same PR interval, but there is P weight absent QRS complex, which you need to remember. Okay. Next is third degree heart block, and the atria and ventricles beat independently of each other. P wave and QRS complex, not rhythm. Atria rate is greater than ventricular rate, usually treated with the pacemaker, can cause by limb disease. Okay. Then next we have the atrial flutter fibrillation, which is chaotic and erratic baseline with no discrete P wave in between, irregularly spaced QRS complex. So what happens is we see the RR interval is not equal in case of atrial fibrillation, and there is no discrete P wave in between, irregularly spaced QRS interval, irregular. Okay. Heartbeat, most common risk factor includes hypertension, coronary artery disease, occasionally seen after episode of excess alcohol consumption, holiday heart syndrome, can lead to thromboembolic event, particularly stroke. Treatment is anticoagulation, rate and rhythm control, cardioversion. Definitive treatment is catheter ablation, left atrium. Atrial flutter, that is the RR interval is equal to RR, next RR interval. It has sawtooth appearance and or rapid successive identical back-to-back atrial depolarization waves. The identical occurs for sawtooth appearance of the flutter wave. Like the atrial fibrillation, catheter ablation of the region between tricuspid annulus and IVC. Okay, so ventricular fibrillation is simply a complete erratic ventricular with no definitive identical waves, fatal arrhythmia without immediate CPR and defibrillators. So the next is the Wolff-Parkinson-White syndrome. So here there is a presence of delta wave. So most common type of ventricular pre-excitation syndrome, abnormal fast accessory conduction pathway from atria to ventricle, bundle of Kent, bypass the rate slowing AV node, ventricular beats begins to particularly depolarize earlier, characterized by delta wave with widening QRS complex and shortened PR wave. With widened QRS complex and shortened PR wave, ECG may result in reentrant circuit and supraventricular tachycardia. So the next is the hereditary canalopathies, that is inherited mutated of cardiac ion channels, abnormal myocardial action potential, increased risk of ventricular tachyarrhythmias and sudden cardiac death. So we have the hereditary angiochannelopathisma, we have Brugada syndrome and congenital long QT syndrome. In Brugada syndrome is autosomal dominant, most commonly due to loss of function mutation of sodium channels. So there is increased prevalence in Asian males, ECG pattern of pseudo-right bundle branch block and ST segment elevation in lead V1 and V2, prevent SCD and implantation cardioverter defibrillator. So Brugada syndrome is basically the most common due to the loss of function of mutation of sodium channel, and there is ECG pattern of pseudo-right bundle branch block and ST segment elevation in lead V1 and V2. So prevent by SCD with implantable cardioverter defibrillator, that is ICD. And we have the congenital long QT syndrome, mostly due to the loss of function mutation in potassium channel. So one Brugada means sodium, congenital QT long means potassium channel effect repolation included. It includes the Romano-Wardau syndrome, autosomal dominant, that is pure cardiac phenotype and no difference. Whereas Jarvelo and Lange-Nielsen syndrome is autosomal recessive and there is sensorineural hearing loss. We have torsades point, which is Polymorphic ventricular tachycardia, characterized by shifting sinusoidal waveform on ECG, can progress to ventricular fibrillation. Long QT interval predisposed to torsades point, caused by drug, decreased potassium, decreased magnesium, decreased calcium, congenital abnormalities, treatment with magnesium sulfide. So we have the drug-induced long QT is A, B, C, D, E. So A for arrhythmias class 1A and class 3 causes the long QT interval. Then B for macrolides and fluoroquinolones, which I am having. And the psychotics, the haloperidol and ziperidone. Antidepressant like TCAs, antiemetics like ondansetron, and antifungals like azoles. Torsades points, twisting of the point. So we have the paroxysmal supraventricular tachycardia, which is a narrow QRS complex tachycardia. So it most often due to atrioventricular nodal reentrant tachycardia, commonly present with the sudden onset palpitation, diaphoresis, and lightheadedness. Treatment terminate re-entry by slowing AV node conduction, vagal maneuver, IV adenosine, electrical cardioversion if hemodynamically unstable. Definitely it means catheter ablation or reentrant tracts. So the next is the atrioseptal, the LAD is V1 to V2. Atrioapical is the distal LAD, that is V3 and V4, and anterolateral is LAD or LCX, that is V5 to V6. In lateral LCX we have 1 and AVL. In inferior RCA we have the 2, 3 and AVF, and posterior PDA we have V7 to V9, ST depression in B1 and B3 with tall RPF. In diagnosis of myocardial infarction, in the first 6 hours, this is the gold standard. Cardiac troponin rises after 4 hours and peak in 24 hours and increase for 7 to 10 days. More specific, CKMB rises after 6 to 12 hours, peak at 16 to 24 hours, and is predominantly found in myocardium but can cause from skeletal muscles, and used in diagnosing reinfarction. CKMB used in diagnosing reinfarction following acute MI because of level non-return normal at after 48 hours. Large MI leads to greater elevation in troponin 1 and CKMB. So ECG change can include ST elevation, that is STEMI, transmural infarction, and the ST depression. So non-ST is subendocardial infarction, hyperacute peak T-wave inversion, new bundle left bundle branch block, and pathological Q-wave or R-wave progression. So basically when you talk about the MI in 0 to 24 hours, there is like light microscopic wavy fibers 0 to 4 hours, only coagulative necrosis 4 to 24 hours, cell content release into the blood, edema, hemorrhage, reperfusion injury, free radical increased calcium, hypercontraction of the myofibrils, and there is ventricular complication can lead to ventricular arrhythmia, heart failure, and cardiac shock in 0 to 24 hours. 1 to 3 days there is post-infectious fibrous pericarditis, there is extensive coagulative necrosis, tissue surrounded by infarct, acute, there is neutrophils. In 3 to 14 days, macrophage, then granulation tissue at margin, febrile rupture, tamponade, papillary muscle rupture, interventricular septal rupture due to macrophage mediated structural degradation, left to right channel, left ventricle pseudoaneurysm, disc cup rupture. 2 weeks to several days, there is gestational syndrome, heart failure, arrhythmia, true ventricular aneurysm, and risk of mural thrombosis. So angina stable, we have the greater than 70% occlusion. There is ST depression on ECG, and vasospastic or pancreatal or variant angina secondary to coronary artery spasm, transient ST elevation on ECG, tobacco smoking, and trigger includes the cocaine, alcohol, triptans, treated with the calcium channel blocker, nitrites, and smoking cessation. Unstable thrombosis with incomplete coronary artery occlusion, ST depression, or T-wave inversion in ECG, but no cardiac biomarkers. Increased frequency or intensity of chest pain or any chest pain at rest. So we have the coronary steal syndrome, which is distal to coronary stenosis. Vessels are maximally dilated at baseline. Administration of vasodilators, dipyridamole or rigadenosone. Okay, so coronary steal syndrome, what happens? There is dipyridamole and digadenosone dilates normal vessels. Blood is shunted towards well perfused area. Ischemia in myocardium, perfused by stenosed vessels. Principle behind pharmacology is stress test with coronary vasodilators. We have sudden cardiac death. Death occurs within 1 hour, most commonly due to lethal arrhythmias, ventricular fibrillation, as with the CAD, cardiomyopathy, hypertrophy dilated, and hypertrophy ion channels, long QT syndrome, Brugada syndrome, prevent with ICD. Next is we have the chronic ischemia heart disease, that is progressive onset heart failure over many years due to chronic ischemia and myocardial damage. So there is myocardial hibernation, potentially reversible, left ventricle systolic dysfunction in setting of chronic ischemia, and there is contrast with the myocardial stunning or transient left ventricular systole dysfunction after a brief episode of acute ischemia. So in the myocardial infarction, most often due to rupture of coronary artery atherosclerosis plaque, acute thrombosis, biomarkers are CKMB, we have non-ST elevated and ST elevated. The ST non-ST elevated is ST depressed on ECG, subendocardial inner, especially vulnerable to ischemia, and subendocardial infarction. Whereas ST segment elevation, there is transmural infarct, full thickness of myocardium wall involved, ST elevation, pathological QA1, ECG. So next we have the traumatic aortic rupture due to trauma or deceleration injury, most commonly at aortic isthmus, proximal descending aorta, just distal to the origin of left subclavian artery. So aortic dissection, there is longitudinal intimal tear forming a false lumen as with the hypertension, bicuspid aortic valve, inherited connective tissue disorder, Marfan syndrome can present with tearing, sudden onset chest pain, ready to back, and markedly unequal BP in arms. So aortic dissection, unequal BP in the arms result in organ ischemia, aortic rupture, death. Stanford A proximal involves the ascending aorta, may extend to aortic arch or extend descending aorta, may result in acute aortic regurgitation or cardiac tamponade surgery. Stanford B involves only descending aorta below the left subclavian artery. Treatment is beta blocker, then vasodilators. Now we have the subclavian steal syndrome, that is stenosis of the subclavian artery proximal to the origin of vertebral artery, hyperposition distal to stenosis, reversible blood flow into the ipsilateral vertebral artery, and reduced cerebral perfusion on exhaustion of an affected arm. Cause arm ischemia, pain, and paresthesia, vertebral vascular insufficiency, decrease greater than 50 mm, BP difference in systolic BP between arms, 50 mm difference in systolic BP between arms. As with the atherosclerosis, Takasago, arthritis, and heart surgeries. So the next we have the aortic aneurysm, that is abdominal and thoracic. So abdominal aneurysm as with the atherosclerosis. This factor includes tobacco smoking, increases male sex, family history, palpable positive abdominal mass, point to out the outer dilated calcified aortic wall with partial crescent-shaped non-opacification of aorta due to the flap clot, often in infrarenal distal to origin of renal arteries, often infrarenal. Abdominal aorta is often infrarenal. And thoracic abdominal aortic aneurysm as with the cystic medial degeneration. Risk factor includes hypertension, bicuspid aortic valve, connective tissue disorder like Marfan syndrome as with the tertiary syphilis, obligatory and arteries of the vasa vasorum, aortic root dilation may lead to aortic valve regurgitation. Similarly, we have the atherosclerosis, that is the abdominal aorta greater than coronary artery, greater than popliteal artery, greater than carotid artery, greater than sarcophagus, or copycat name Williams. Abdominal aorta greater than coronary artery, greater than popliteal artery, greater than carotid artery, and with circular filling. So modifiable risk factor includes hypertension and all, non-modifiable age, male sex, postmenopausal status, and family history. So inflammation important in pathogenesis, endothelial cell dysfunction, macrophage LAD accumulation, foam cell formation, and smooth muscle migration, PDGF and FGF, proliferation, extracellular matrix, fibrous plaque, complex atheroma, calcifications. So the next is the Monkey-Berg sclerosis, which is the medial calcification sclerosis after medial vessel arteritis. Is the internal elastic lamina and the media of the arteries calcification. So vascular stiffening with obstruction, pipe stem appearance on X-ray, does not obstruct the blood flow, intima not involved. In atherosclerosis often affect the small arteries and arterioles, hyaline, thickening of the vessel wall secondary to plasma protein leak into endothelium is essential. Hypertension or diabetes mellitus, hyperplastic is onion skinning, in severe hypertension with proliferation of smooth muscle cells. We have the hyperlipidemia sign, the xanthomas, plaque or nodules composed of lipid-laden histiocytes in skin. We have tendinous xanthomas, lipid deposit in tendon, especially Achilles and finger extensors. Cornus, corneal arcus, lipid deposit in cornea. In elderly, arcus synovitis, but appear earlier in life with hypercholesteremia. So next is the hypertension, that is more common in black, white than Asian, and is greater than 130 and BP 80. So 90% hypertension as primary hypertension, often related to increased QA, and remaining 10% mostly secondary to renal venous vascular disease such as fibromuscular dysplasia. There is characteristic stiffening, string of beads, appearance of renal artery. So hypertensive urgency is severe greater than 180 by 120 hypertension without end organ damage, and hypertensive emergency severe hypertension with evidence of acute organ damage, encephalopathy, stroke, retinopathy, hemorrhage, exudative pulmonary edema, MI, HVAF, aortic dissection, kidney injury, microangiopathic, hemolytic anemia, and eclampsia. predisposed to CAD, LVH, HF, atrial fibrillation, aortic dissection, aortic aneurysm, stroke, CKD, retinopathy. So some of the defects that is associated with the prenatal alcohol exposure, VSD, PDA, ASD, and 2F, with congenital rubella, PDA, pulmonary to artery stenosis, and septal defect. With Downs, we have the AV septal defect, endocardial percent defect, and VSD and ASD. So infants or patients with diabetic during pregnancy, transposition of great vessels, and BSD. So Marfan, we have the MVP, thoracic aortic aneurysm, dissection, aortic regurgitation. So in the Turners, we have bicuspid aortic wall, aortic coarctation of aorta. Williams is supravalvular aortic stenosis. 22q11 syndrome is truncus arteriosus and tetralogy of Fallot. So the next topic to discuss is the right to left shunt, that is the early cyanosis, often diagnosed prenatally. So it has the one vessels problem, that is the truncus arteriosus. Truncus arteriosus fails to divide into pulmonary trunk and aorta due to failure of the aortic pulmonary septum. Most commonly we have the VSD. So next is transposition of two vessels. Aorta leaves from the right ventricle and pulmonary trunk leaves the left ventricle posteriorly. Separation of the systemic and pulmonary separation not compatible with them unless a shunt is present to allow the mixing of the blood. So VSD, PD, or patent doctors for foramen open. Due to failure, aortic pulmonary septum spiral, egg on the string, appearance, CS actually. Without surging enter, most infants die within the few weeks. Now next we have the tricuspid atresia, absence of tricuspid valve and hypoplastic right ventricle, often requires ASD and VSD for viability. Tetralogy of Fallot, anterior superior displacement of caused by anterior superior displacement of infundibular septum, most common cause early childhood cyanosis, pulmonary intervalvular stenosis, most important determining prognosis, right ventricle hypertrophy, boot-shaped heart on chest X-ray, overriding aorta, and VSD. So there is the squatting increase the systemic vascular resistance and decrease right to left shunt, improve cyanosis. So as to with the 22q11 syndrome. So pulmonary stenosis forces right to left flow across the VSD, right ventricular hypertrophy, dead spells often caused by crying, fever, anxiety due to exacerbation of right ventricular outflow obstruction. So total anomalies, pulmonary venous return is pulmonary vein drain into the right heart circulation, SBC or coronary sinus issue with the ASD and sometimes PDA to allow the right to left shunting to maintain the cardiac output. If anomaly is issue with the tricuspid regurgitation, accessory conduction pathway, right side heart failure can cause by lithium. Next is the last topic, we have left to right shunt, which is the asynetic at present, but cyanosis may present occur later. Frequency VSD greater than ASD greater than PDA. So right to left shunt early cyanosis, left to right shunt late cyanosis. Ventricular septal defect or syndromic at birth may manifest weeks later. So most resolves larger lesion may lead to left ventricle overload and heart failure. O2 saturation increase in right ventricle and pulmonary artery. So we have the atrial septal defect in the atrial septum, wide fixed split. S2 ostium secundum defect, most common usually on isolated finding. Ostium primum defect rare, usually occurs with other cardiac arteries. Symptoms range from non to heart failure. Distance from patent foramen in the septa are missing tissue rather than unfused. So O2 saturation increase in RA and RV and pulmonary arteries. So in atrial septal defect, increase O2 saturation in RA, right ventricle, right atrium, pulmonary artery may lead to paradoxical emboli, systemic venous emboli used to ASD to bypass lungs and become systemic artery emboli. As with the ASD as with the Down syndrome. So patent ductus arteriosus, PDA is normal in utero and normal closed only after birth. In fetal shunt is right to left. Neonatal decreased pulmonary vascular resistance, decreased shunt becomes left to right. Progressive right ventricular hypertrophy or left ventricular hypertrophy in RPS with the continuous machine like PDA as with continuous machine like model. Patency is maintained by prostaglandin in low oxygen tension. Uncorrected PDA animation is on delayed cyanosis in lower distributed differential cyanosis. So Eisenmenger syndrome, uncorrected left to right shunt, VSD, ESD, and PDA, increased pulmonary blood flow, pathological remodeling of vasculature, pulmonary artery hypertension, and right ventricular artery occurs to compensate the shunt becomes right to left. Cause left cyanosis, clogging, and polycythemia. Age of onset depends on size and severity of initial left to right shunt. So we have coarctation of aortic narrowing near the insertion of ductus arteriosus, aortic wall or the heart defect, and the so with the bicuspid aortic wall or the heart defect, Turner's, hypertension in upper extremity, weak delayed pulse in lower extremity, brachiofemoral delay. With age, intercostal arteries enlarges due to the collateral circulation, artery erodes ribs, and notches appears on the chest X-ray. Complication includes heart failure, increased cerebral hemorrhage, berry aneurysm, aortic rupture, and possible endocarditis. Thank you. So now we are starting the cardio drugs. So here in this case we have the hypertension. treatment, we have dihydropyridine, calcium channel blockers, and hypertension with heart failure. We give first line is diuretics, ACE inhibitors or ARB or beta blockers or aldosterone antagonist. Only no calcium channel blockers in heart failure. Beta blockers must be used cautiously in decompensated heart failure and are contraindicated in cardiogenic shock. So in heart failure, ARB may be combined with the neprilysin inhibitor sacubitril. In heart failure, ARB may be combined with the neprilysin inhibitor sacubitril. In hypertension with diabetes, we give AC or ARB, calcium channel, thiazides, diuretic or beta blockers. So AC inhibitors ARB are protective against diabetic nephropathy. Beta blockers may mask the hypoglycemic symptoms. In hypertension in asthma is ARB, calcium channel blockers, thiazides, diuretic, cardioselective beta blockers. Avoid non-selective beta blockers to prevent the beta 2 receptor induced bronchoconstriction. Avoid EC inhibitors to prevent the confusion between the drug or asthma-related cough. So hypertension in pregnancy is nifedipine, methyldopa, labetalol, hydrazine, new mom Lovox. So the next is the cardiovascular agent and molecular targets. Here the GQ agonist is epinephrine or norepinephrine that works in alpha 1, endothelin 1, angiotensin 2, and vasopressin that acts on the GQ and gives the IP3, and it induces the sarcoplasmic reticulum calcium. Similarly, we have the dihydroquinidine calcium channel blocker. So that's amlodipine, clevidipine, nicardipine, nifedipine, and nimodipine that acts on the L-type voltage-gated calcium channels that induces the calcium carbonyl complex. And then we have the GS agonist like the epinephrine beta 2, prostacyclin, prostaglandin, pendolpan D1, and adenosine that stimulates the GS, and GS stimulates the adenyl cyclase, whereas GI inhibits the adenyl cyclase, that is the epinephrine or norepinephrine alpha 2 that acts to alpha 2 inhibits the positive the GI and inhibits the adenyl cyclase. Adenyl cyclase converts the AMP to CAMP and it inhibits the myosin light chain kinase. Similarly, we have the myosin MLC phosphatase that converts the CGMP to GTP, and this action is created by PDE5. So PDE5 is inhibited by sildenafil, and the arginine, the acetylcholine alpha 2 agonist, bradykinin, cytokine, histamine, serotonin, or shear stress induces the receptor vascular lumen, endothelial cells secretes the NO diffuses into the smooth muscle cells. So this is the smooth muscle cells we are talking about, and the smooth muscle cells here the NO positive the reaction between the GTP to CGMP, whereas CGMP is converted to GTP by PDE5. So CGMP now activates the myosin light chain phosphatase and it does relaxation. And the GQ induces the IP3 to the sarcoplasmic reticulum, whereas ryokinase inhibits the myosin phosphatase. Okay, and ENP, BNP, and neseritide are the positive nitrouretic peptide precursor that also activates same as the function as NO, and it activates the CGMP. We have the milrinone, which is activating the phosphodiesterase 3 that is converting the CAMP to AMP by phosphodiesterase 3 that is breaking the CAMP. So milrinone inhibits the PDE3. This is all in the vascular smooth muscles. Okay, so now we have the calcium channel blockers. That is the diltiazem and verapamil are the non-dihydropyrimidine that acts in heart. So no water in the heart. So amlodipine and clevidipine, nicardipine, nifedipine, they acts on the vascular smooth muscles. So vascular smooth muscles, amlodipine greater than equal to nifedipine is greater than diltiazem and verapamil. When in the heart, verapamil greater than diltiazem is greater than amlodipine equals to nifedipine. So nimodipine is causing the subarachnoid hemorrhage, so prevents the cerebral vasospasm, whereas nicardipine is clevidipine, used in the hypertensive urgency or emergency, and non-dihydropyrimidines are used in hypertension, angina, atrial fibrillation or flutter. So adverse effect of calcium channel blockers are gingival hyperplasia, dihydropyridine cause peripheral edema is asked question. So dihydro means the amlodipine causes peripheral edema, and non-dihydro, that is cardiac depression, AB block, hyperprolactemia. Verapamil asked question. Verapamil cause hyperprolactemia, very high yield, and constipation by non-dihydropyridine. Non-पानी वाला भनेको चाहिँ मुटुमा काम गर्ने है. अनि हाइड्रोलाजिन increase the CMP, smooth muscle relaxation, is a vasodilator, arterioles greater than vein, after load, severe hypertension, heart failure, often with nitrates, safe to use in pregnancy, frequently co-administered with the beta blocker to prevent the reflux tachycardia. So hydralazine is co-administered with the beta blocker to prevent reflux tachycardia, compensatory tachycardia, contraindicated in angina, fluid retention, headache, angina, and drug-induced lupus. Hypertensive emergency, treated with the labetalol, clevidipine, fendolpan, nicardipine, and nitroprusside. So nitroprusside is a short-acting vasodilator, increases CGMP by direct release of NO, can cause cyanide toxicity. So fendolpan is dopamine D1 receptor agonist. Coronary, so fendolpan is dopamine D1 receptor agonist, coronary, peripheral, renal, and splenic vasodilation, decrease BP, increase natriuresis. Also used post-operatively as an antihypertensive, can cause hypotension, tachycardia, flushing, headache, and nausea. So nitrates are nitroglycerin, isosorbide dinitrate, isosorbide mononitrate, vasodilates by increase NO in vascular smooth muscles, increase CGMP, smooth muscle relaxation, dilate vein greater than arteries, decrease preload. So nitrates are clinically used in angina, acute coronary syndrome, and pulmonary edema. Nitrates adverse effects are reflex tachycardia, treated with the beta blockers, hypertension, flushing, headache, Monday disease. In industrial nitrate exposure, development of tolerance for vasodilatory acting during the work week, and loss of tolerance over the weekend, tachycardia, dizziness, headache, upon re-exposure. Contraindicated in right ventricular infarction, hypertrophic cardiomyopathy with concurrent PDE5 inhibitors use. So we have the anginal therapy. Basically the nitrates decreases the end diastolic volume, decreases the blood pressure, decreases the ejection time, and decreases the MbO2, whereas there is a reflex increase in heart rate and contractility, whereas the beta blockers decreases all of these but only increases the ejection time, okay, and the end diastolic volume. So beta blockers increases the end diastolic volume and ejection time, whereas it decreases the blood pressure, contractility, heart rate, and MbO2. So nitrates plus beta blockers are very effective. So together they have no effect on end diastolic pressure, decrease in BP, little or no effect on contractility, no effect or decrease in heart rate, ejection time is little or no effect, MbO2 is significantly decreased. So verapamil is similar to beta blocker in effect, and pindolol and acetobutolol are partial beta agonists that should be used in caution in angina. So ranolazine inhibits the late phase of inward sodium current, thereby reducing diastolic wall tension and oxygen consumption. So it is used in refractory angina, adverse effect, constipation, dizziness, headache, and nausea. We have sacubitril, which is a neprisyl inhibitor, prevent degradation of bradykinin, natriuretic peptide, angiotensin 2, and substance P. So is increased vasodilation, decrease ECF volume, used in combination with valsartan or ARB to treat heart failure with reduced ejection fraction. So adverse effect of sacubitril is hypotension, hyperkalemia, cough, dizziness, contraindicated with AC inhibitors due to angioedema. Both drugs increases bradykinin. So the next is we have the lipid lowering drugs, that is the HMG-CoA reductase. So it atorvastatin and simvastatin inhibits the conversion HMG-CoA to mevalonate, a cholesterol precursor, decrease intrahepatic cholesterol, increase LDL receptor recycling, increase LDL catabolism, and this decreases the triglycerides, decrease the LDL, increase the SDL. Adverse effect is hepatotoxicity, myopathy, especially when used with fibrates, niacin. So bile acid resin, that is cholestyramine, cholestyramine, and cholecsivalam is there is increase in triglycerides, increase in SDL, whereas decrease in LDL. Prevent intestinal reabsorption of bile acid. Liver must use cholesterol to make more. So there is GI upset, decrease absorption of other drug and fat soluble vitamins. We have ezetimibe, which is prevent cholesterol absorption in small intestine. There is decrease in LDL, a decrease in triglycerides, and increase in HDL. So we have the fibrates, zemifibrates, benzafibrates, and phenofibrates, which activates the PPAR alpha, upregulate LPL, and increase triglyceride clearance. Activate PPAR alpha induce HDL synthesis. So there is adverse effect on myopathy and increased risk with statin, gallstone by inhibition of cholesterol 7 alpha hydroxylase. So there is decrease in triglycerides, increase in HDL, and decrease in LDL. So we have the niacin, that is inhibit lipolysis, hormone sensitive lipase in adipose tissue and reduce hepatic VLDL. So it decreases the LDL, increases the HDL, and decreases the triglycerides. The adverse effect is flushed faces, prostaglandin mediated decrease by NSDs, or long term it causes hyperglycemia and hyperuricemia. So we have PCSK9 inhibitors, that is called elidosumab and evolocumab. Elidosumab and evolocumab that decrease the LDL, increase the HDL, and decrease the triglyceride. Inactivation of LDL receptor degradation, increase removal of LDL from bloodstream. So adverse effect is myalgia, delirium, dementia, and neurocognitive dysfunctions. Fish oil and marine omega-3 fatty acid slightly increase LDL, slightly increase HDL, and decrease at high dose in the triglycerides. So believed to decrease the FFA, deliver to liver, and decrease activity of triglyceride synthesizing enzymes, nausea, and fish-like taste. So the next is the cardiac glycosides, digoxin, which directly inhibits the sodium potassium ATPase, inhibits inhibition of sodium calcium exchange, and increases calcium positive inotropes, stimulates vagus nerve, and decreases heart rate. Clinical use in heart rate, increase contractility, and use in atrial fibrillation, decrease conduction and AV node, and depression of SA node. So adverse effect of digoxin is cholinergic effects. It has nausea, vomiting, diarrhea, blood vision, think can glow, arrhythmia, and AV. Can lead to hyperkalemia, which indicates poor prognosis. Factor patient to toxicity is renal failure, hypokalemia, binding at potassium site on sodium potassium ATPase, drug that displaces the digoxin from tissue binding sites and decrease clearance, verapamil, amiodarone, and quinidine. Antidote for digoxin is slow normalized potassium, cardiac pressure, anti-digoxin, FAP fragments, and magnesium. So normalized potassium, calcium pressure, anti-digoxin, FAP fragments, and magnesium. Now at the last we have the antiarrhythmic drugs, that is slow or block the conduction, especially in depolarized cells, decrease slope of phase 0 depolarization, increase action at faster heart rate, state dependence, increase heart rate, shorter diastole, sodium channel, spend less time in resting effect state, drug diastolic during this state, less time for drug to dissociate from receptor, effect most pronounced in C-cab due to relative binding strength, fast taxi cab. So class 1A is quinidine, prokinamide, and disopyramide. So 1A drug has moderate sodium channel blockade. So one that original is the one, and the with the drug the blue line goes inside, and from the first one, and the blue line goes outside from the second one. So there is moderate sodium channel blockade, increased AP duration, increased effective refractory period in ventricular action potential, increased QT interval, and some potassium channel blocking effect. So clinical use in atrial and ventricular arrhythmias, especially reentrant and ectopic SVT and ventricular tachycardia. So the adverse effect of one is synonism, headache, tinnitus with quinidine, reversible SLE syndrome with procanamide, HF heart failure with the disopyramide, thrombocytopenia, torsion point due to increased QT interval. Now next we have the 1B. So 1B, so body rice available with rare axine. So B is inside. So weak sodium channel blockade, decrease AP duration, and preferentially affect the ischemia or depolarized Purkinje and ventricular cells. These drugs are lignocaine, phenytoin, and mexiletine. So lignocaine, phenytoin, and mexiletine are weak sodium channel blockade, decrease AP duration, preferentially affect ischemia or depolarized Purkinje or ventricular tissue. So best after post MI. So clinical use in post MI, least used arrhythmia and acute ventricular arrhythmia, especially post MI. So adverse effect is CNS stimulation, depression, and cardiac depression. One C is flecainamide, propafenone. So Here the first goes inside, okay, more one, and the second one, blue line is on the line only. So flecainamide and procafagon. So strong sodium channel blockade significantly prolongs ERP in AV node and necessary bypass tract. No effect on ERP in Purkinje and ventricular tissue. Minimal effect on action potential. SVT, clinical use in SVT including atrial fibrillation only as a last resort in refractory VT. So adverse effect of 1C is post proarrhythmic, especially post MI, contraindicated. IC is contraindicated in structural and ischemic heart diseases. So next we have the antiarrhythmics, beta blockers, that is class 2. We have the metoprolol, propranolol, esmolol, atenolol, timolol, and carbidopa. So the beta blockers decreases the SA node and AV node activity by decreasing the CAMP, decrease calcium current, suppress abnormal pacemaker by decreased slope of phase 4, and AV node particularly sensitive, increase PR interval, esmolol very short acting. SBT, ventricular rate control for atrial, clinical use in SBT. Beta blockers use supraventricular tachycardia, ventricular rate control for atrial fibrillation and atrial flutter. Adverse effect of beta blockers is impotence, exacerbation of COPD and asthma, okay, and cardiovascular effects, bradycardia, AV block, heart failure. CNS effect like sedation and sleep alteration may mask the sign of hyperglycemia. Metoprolol causes dyslipidemia. Propranolol can exacerbate vasospasm in vasospastic angina. Beta blockers, except the non-selective alpha and beta antagonists, carbidopa and levodopa, cause unopposed alpha agonism if given alone for pheochromocytoma or cocaine toxicity. So treatment beta blocker overdose with the saline, atropine, and glucagon. Treatment of beta blocker overdose with saline, atropine, and glucagon. So decreases the slope at the for depolarization and prolonged depolarization at AV node. Okay, and then we have the class 3, the antiarrhythmics. So that is the AIDS. So that is the sodium potassium channel blockade, amiodarone, ibuletide, dofilitide, and sotalolol. Amiodarone, ibutilide, dofilitide, and sotalolol. So here there is increase in AP duration, increase in ERP, increase in QT interval, atrial fibrillation, used in the atrial fibrillation, atrial flutter, ventricular tachycardia. So adverse effect are sotalolol, torsade is point, excessive beta blockade, ibutilide is torsade is points, amiodarone causes pulmonary fibrosis, hepatotoxicity, hypothyroidism or hyperthyroidism. Amiodarone is 40% iodine by weight and acts as a heptane, corneal deposit, blue-grayish skin deposit resulting in photodermatitis. Neurological effects, constipation, cardiotoxicity effect, bradycardia, heart block, and heart failure. Remember to check PFT, LFT, TFT when using amiodarone. Amiodarone is lipophilic and has class 1, 2, 3, and 4 effects. Okay. So the last drug that we will be talking about, the antiarrhythmic calcium channel blockers, class 4, diltiazem and benabiven, that acts in the heart. It decreases the conduction velocity, it decreases the ERP, increase PR interval, prevention treatment, clinical use in prevention of nodal arrhythmia, SVT, rate control in atrial fibrillation. Adverse effects as constipation, flushing edema, cardiovascular, heart, HF, AV block, and sinus node depression. So other antiarrhythmics are adenosine, increase potassium out of the cell, hyperpolarization of the cell, decrease calcium, decrease AV node conduction, drug of choice in diagnosing termination of certain form of SBT, varying short acting, 15 seconds, effect blunt by theophylline and caffeine, both are adenosine receptor antagonists. Adverse effects include flushing, hypertension, chest pain, sense of impending doom, and bronchospasm. So magnesium, effective in torsade is point, and digital toxicity. Ivabradine mechanism, ivabradine prolongs slow depolarization by selective inhibiting funny sodium channels. Clinical use in chronic stable angina in patient who takes beta blockers and chronic heart failure with reduced ejection fraction. So adverse effect is luminous phenomenon, visual brightness, hypertension, bradycardia with the ivabradine. Thank you.